cholecystitis or gallbladder disease، لأنه أفضل نقول gallbladder disease لو هنتكلم على كذا شيء. لما واحد يقول or somebody says cholecystitis, you assume وتتوقع إنه always he means calcular meaning stones. نادرا ما حتسمع أحد يقول acute calcular cholecystitis، خلاص هيقول لك acute cholecystitis or chronic cholecystitis، لأنه أكثر من 95% من الوقت بتكون الكوز ستون which is the commonest، فما يقولوا calcular. لكن لو كانت cholecystitis من غير ستون هتسمعهم يقولوا acute مثلا acalcular cholecystitis. فدائما assume إنه cholecystitis is stone until mentioned otherwise. And the commonest is acute calcular cholecystitis. At the end of the lecture, we'll talk about the other types briefly لأنها less common, ولكن you have to know about them. So we'll talk about the anatomy of the gallbladder, which is very important, عشان تعرفوا how it happens and how things occur. With definition, etiology, and the risk factors of cholecystitis, all of them. Pathophysiology, how does it occur? Presentations of the patient, differential diagnosis, investigation, and then we'll talk at the end, as I said, about the acalcular types of cholecystitis. Anatomy. Gallbladder is a pear-shaped organ. Pear يعني كمثرى. Its function is to concentrate bile. So what it does, it gets the bile from the liver and concentrates it. It absorbs water, so it becomes concentrated, and stores it when you need. So what happens once it's in the gallbladder and you eat, food enters into the duodenum, CCK is released by the stimulus of food in the duodenum, which contracts the gallbladder to eject the bile into the common bile duct, and at the same time it relaxes the sphincter of Oddi, so the bile enters into the duodenum. It keeps going with the duodenum and mixes until and form the micelles, as you all know, in the small bowel to aid and facilitate the absorption of fat through the small intestine. The excess bile then is, and we will talk about this again and show you, reabsorbed in the terminal ileum back into the liver, and a very small amount of bile is secreted from the stool. And this is what gives the stool the brown color. And this is why we say in obstructive jaundice you have pale stool. Pale stool because there is no bile that mixes with the stool, for the stool becomes pale because, as I said, the bile salts give you this color. This is the whole they call it intrahepatic circulation. هذا كده on the side. نرجع تاني للاناتومي. We said it's a pear shape, concentrates the bile. It's situated under the liver, and this is when we do Murphy sign or we examine the abdomen, we move the liver because it's attached to the liver, so then it comes down on abdominal examination. What do we mean by acute calcular cholecystitis, or as I said at the beginning of the lecture, of acute cholecystitis? From the term cholecystitis, it means inflammation of the gallbladder. طبعا itis وأنا مركز على itis هذه, it means inflammation or infection of an organ, you have to differentiate between the two. In the gallbladder, it is inflammation. So acute cholecystitis or acute calcular cholecystitis is acute inflammation of the gallbladder. It is usually due to occlusion of the cystic duct by stones. This is the commonest, 95%, as I told you at the beginning, the cause of cholecystitis. Obstruction of the cystic duct by a stone. How does the stone obstruct? زي ما قلنا في البداية, when you eat, CCK contracts the gallbladder, so the stone moves زي البايل to try and get out of the gallbladder. So if the stone is very small, it will come out from the gallbladder through the cystic duct into the common bile duct ويخرج from the ampulla, and this happens a lot, and a lot of times it's normal. However, if the stone gets a little bigger, and we'll talk about the causes soon, then while it's going through the cystic duct or at the beginning of the cystic duct, it lodges and blocks the way. So when it blocks the way, you will have contraction against resistance because of this ايش في رزان. Okay, so this blockage will be the bile will contract against the blockage, and this is when pain starts to happen. زي البنكرياتايتس, backflow of the bile into the gallbladder will start to cause injury to the lining mucosa, and this will cause the inflammation. Once the inflammation happens, you start to have right upper quadrant pain. You can have fever, white cell count, Murphy, طبعا LFT هذه, we'll talk about it later on. It's not always the case. Even fever, even white cell count, depends on the degree of the inflammation, and you will have a positive Murphy sign on examination. So this is the simple scenario of how does acute calcular cholecystitis happen. It is a surgical emergency, and I'm talking about acute cholecystitis. Okay, it starts, as I said, by chemical irritation of the bile. There is no infection. This is a very important part. More than 95% of the time, always, it's inflammation that injures the mucosal lining, exposure to destructive bile salts. Very small number, about 5%, will get a superimposed bacterial infection. And once you get the bacterial infection, it changes. Okay? It doesn't become cholecystitis anymore. It starts to go into the complications, and you start to perform pus. Patients become septic, more febrile, and it starts to be called a different diagnosis, which we call complicated gallbladder disease. It's one of the complications. So you do not call it anymore acute cholecystitis when you have infection. It is called complicated gallbladder disease, which is one of the types of infection that you can happen to acute cholecystitis. إذا حد عنده سؤال, he can ask anytime, right? And I will try to answer him, or at the end, it's up to you. It doesn't make a difference with me, really. So as we said, the definition is cholelithiasis, or which equals gallstone. This is everywhere, cholelithiasis, or colidoco إذا كانت في common bile duct, or في liver, hepatolithiasis. Doesn't make a difference. Lithiasis means stone. What are the risk factors? For you to understand the risk factors, you don't need to memorize them. because if you try to memorize them, you might forget a few or put a few. Understanding how the stone forms is the best method of getting the risk factors. So I will explain to you how the stone forms, or what's the equation, and then we'll go through the risk factors to try and put each one of them into its category. So as I said, اعتبروا الجول بلر كأنها دائما أنا أقول مسبح، بركة سباحة. What happens؟ بركة السباحة, you always have, if you leave it for a few days, you will start, the color of the water starts to change, يبدأ تخضر، يبدأ يصير فيها foreign material, foreign bodies، تبدأ تصير وسخة. This is normal. So how do you keep the pool clean زي ما يقولوا؟ You always add medications to kill the bacteria, and the filter has to be running all the time. So it means that the water has to be moving, it doesn't stay dormant. So the same thing is with the gallbladder. You need the bile to continue moving around, and the bile doesn't move except when you eat. When you eat, the gallbladder contracts, and the bile goes out, refreshes, and new bile comes in. So it doesn't have a time or a long time to be stagnant. And you have to have the right amount of solubles or bile salt اللي هو الديزولفنت المذيب مع البيجمنتس والكوليسترول عشان تفضل ذايبة وما تكون نواة وتبدأ تكون stones. So if you have dormant gallbladder with no gallbladder contraction, number one. Number two, if you have more cholesterol or more bile pigments, you will end up developing stones. So when we talk about these factors, we try to look at the risk factors with it. Females, as we know, have high estrogen and progesterone. And these hormones are very in charge of the female cycle, and at the same time they are very important, or one of the common causes of bowel stasis. They cause the bowel to be slow, and this is why during the period they have cramps, sorry, and abdominal pain, because the elevated level of estrogen progesterone relaxes the bowel. At the same time, when it relaxes the bowel, it also relaxes the gallbladder, and the gallbladder works less. So this is why the females are more prone, because of the female hormone, to develop gallstones. The fat is because of the high cholesterol. قلنا المذيب والمذاب. If you have more cholesterol, زي كاسة الشاي، تحط فيها، تجيب لي كاسة صغيرة أو نص فنجان وتحط فيها ملعقتين 3 سكر، ما حتدوب لو إيش ما تعمل. It's the same issue. If you have too much fat in the bile salts will not be enough to dissolve it. So at the end of the day, you will have nuclei and extra that will form the stones. 40 or 50 they call it, which is the age, and this is the same story. Because of the high risk of pregnancy, which is an extra doses of estrogen and progesterone, and usually patients at 40 will have this, will have more, هي 40 والfertile is the same because of the high exposure of the estrogen and progesterone levels during pregnancy. Fertile is the same, she had children, so it's the same story. Fair, if you know what fair means hairy، اللي هي الفيميلز اللي بيكون في عندهم extra hair شعر كتير. And this is the same, they usually have polycystic ovary disease, which is also high in estrogen and progesterone, that will add up to the risk of stones. So these are the common risk factor. They call it the 5F. If you see a female, fat, 40, fertile, and fair, you know most likely she will develop stones in her career, in her life. Now, she can develop stones and have problems, or she can develop stones and not have problems. And we will talk about this later on. Not everybody who develops stones will have complaints or problems. Most of the people actually develop stones, live and die without knowing that they have stones. About 80% actually. They don't have any complaint. Another risk factor is rapid weight loss, the same as the fat. The more you mobilize fat and it goes into the bile, into the liver, the more you have more مذاب على المذيب, and you end up with زي ما قلنا السكر you will end up with more into the bile, so it doesn't get dissolved, and at the end of the day you end up with a nuclei that can form a stone. Fasting is a very bad thing for the gallbladder. And we're talking about prolonged fasting, more than normal fasting, because you will not have CCK, bile will become stagnant into the gallbladder and forms nuclei, and because you are not filtering it or changing the circulation. Same obesity and fatty diet, we said it from the fat. Diabetics are decreased immunity, are more prone to infections. Hyperlipidemia, the same as fat. Hemolytic states is sickle cell, hereditary spherocytosis, thalassemia also, because the same as the issue of cholesterol, these are bile pigments. We know that the RBCs have bile, they have the pigments, which is bile pigments. Once they destruct, you will have more bile pigments into the circulation, which goes into the liver and then into the bile. If it's too high, as we said, just as cholesterol, you will end up with bile bile high pigments, into the stones, and that will lead to pigmented stones, because the types of stone is either cholesterol or pigmented. Bile duct stasis, back again to the same issue of fasting. If you don't release your bile, and you can have the stasis either functional, CCK from fasting, or structural. Structural, we mean obstruction في الطريق. Stricture, congenital anomaly, pancreatitis, anything causing obstruction of the way, that can also lead to a stagnant bile and not recycling. Infections, parasitic infections, Ascaris is one of the ones that has been blamed, and the reason is Ascaris is a long tapeworm that can go into the bile duct and cause obstruction again. So it's the same. It's not because of the worm itself, it's because of obstruction. So all the risk factors are summarized into these things. You have either زي ما قلنا stasis of bile and no recycling, and that can either be structural or functional. Functional من نفس CCK, or from the slowing down from the female hormones, or you can have it structural by obstruction, by any means of obstruction, strictures or worms or pancreatitis or cysts or whatever. The other hand, you can have increase of the substance that are in the bile, which are the two main things, which is cholesterol in fat, or if you have pigmented, like in hemolytic anemias, where you have the pigmented stones. So this is in summary, or in all the risk factors for developing stone in two arms. So again, we'll talk the pathogenesis. I already explained it. We will repeat it again. Now that we know bile is the digestive juice made by the liver, you produce about half a liter. A quarter is a little less, it's more, half a liter, and it digests fat. We said the consistency is bile salts, phospholipids, and cholesterol. Gallstones is usually, as we said, imbalance between the three components. So if you have more cholesterol, more phospholipids, you will end up with stones because the salts cannot dissolve them, either by زي ما قلنا hemolysis or by fat or increased fat diet. Add on top of it that not recycling or emptying the gallbladder, all of this will end up with stone formation. So you have three stages how the stone forms. First, which is the commonest, the cholesterol supersaturation in fat زي ما قلنا. زي لما قلنا تحط ملعقتين 3 سكر في نص فنجان شاي، هيدوب اللي يدوب والباقي هيفضل زي ما هو. When it stays, it forms nuclei, which is a foreign body, not dissolved. This nuclei starts with to grow, the stone starts to grow around it لأنه هذه focus of growth. So again, just a simple drawing to show you how the same thing again. We said, you know that the cholesterol 7 alpha hydroxylase go and decreases into the bile, enters with the cholesterol. All of this goes into the bile, which is all the fat, into the bile and get dissolved. It enters into the gallbladder and starts to get concentrated. If it's not dissolved and you have these small nuclei, it will stay into the gallbladder. ومع زيادة reabsorption من الجولبلر to concentrate البايل بتزيد النيوكلياي وبتكبر. However, this happens in most of the people. So if you eat and you eject the bile, there will be no time for this stone to form. لكن لو كمان أخرت الأكل مرة طولت البايل هذه في الجول بلادر, it will start to perform stones. The stones sometimes can be ejected depending on the size from the cystic duct and the ampulla, and sometimes, they go out, they can't go, and they start to block the cystic duct, and this is when you start to have acute cholecystitis, or we should start by, biliary colic. And we will talk about each one of them now separately. So what happens? The gallbladder, مع contracting against resistance, starts to develop edema and muscular tear with patchy thrombosis of the arterioles and venules. This is because of the contraction against resistance and the bile coming back into the gallbladder, causing injury into the mucosa. They develop area of necrosis develops and affect the underlying mucosa. The theory is that factor 7, it's not theory anymore, it's well established, leads to the blood vessel thrombosis and to the injury to the submucosa. We already talked about this types of stone. قلنا في either cholesterol or pigmented. والcholesterol قلنا من الفات, والpigmented قلنا من الhemolysis or increase in the pigments. The commonest type of stones is mixed, and all of this is due to the decrease of the bile salts itself. اللي هو الشاهي نفسه. الشاهي ده ممكن تدوب فيه سكر أو تدوب فيه، نقول سكر أبيض وسكر بني. فأنت بتحط السكر الأبيض يدوب، بتحط السكر البني يدوب. لكن القصة أكتر common cause إنه نفس الشاهي هو اللي بيقل البايل salts due to a lot of reasons من الليفر و diet wise، وفي a lot of factors into that where it's not the scope of us now. So لما الشاهي يقل بيصير عندك السكر الأبيض قاعد والسكر البني قاعد، اللي هو الكوليسترول والبيجمنتين. الاثنين usually they combine and they form the nuclei and form the stones. So that's why the commonest type of stones is the mixed type. You can have pure cholesterol in 10% and pure pigmented in 10%. The pigmented stones are two types. The black pigment, which is the ones we know. They are usually associated with hemolytic diseases. You will only see them in patients with hemolytic diseases, thalassemia, sickle cell, and spherocytosis that get hemolysis and develop a high level of pigments in the bile. There is a brown pigment stone, لونها brown bunny. We don't have it in our area or in the south. بتكون موجودة في الإيست في آسيا, and it's usually because they have the pigment and they have a certain type of bacterial infection on top of it, giving it this color of brown pigmentation. So you will not see it here إلا لو واحد جاء من الفورنرز زي ما يقولوا من هناك, you can see it. Just the picture you can see on the upper hand, the yellow pigments. You can see then these are the mixed pigments, various types and shapes. You can see a gallbladder like this full of stones, and this is very common. It can happen, we've seen it a lot, and this is also stones from one gallbladder. So the stones can be one single or can be 150. It doesn't make really a big difference. One stone can cause problems, 10 stones can cause same problems. The number is not an issue, or the size even. Both of them are not an issue. The issue is obstruction of the cystic duct by a big stone, a small stone, 10 stones, one stone. It doesn't really make any difference in the appearance or the manifestation. So what happens to patients who come to or present with gallstone disease clinically now? They usually come with right upper quadrant pain. As we said, the pain is due to the obstruction of the cystic duct. So the commonest presentation is pain. It's about 100%. All of them come with pain. They can come with fever, common also, but a little less. Nausea and vomiting is associated with the pain. The more the pain, the more the nausea and the vomiting, as we know. Anorexia, they don't want to eat. Bloating or gasiness is also can be associated. However, we have to know that the sequence of events, and this is very, very important to Shabab. The sequence of events of gallbladder disease. Patients, when they come at the beginning, زي ما قلنا السيناريو. Gallbladder contracts by CCK, stone moves, obstructs the cystic duct. Now, the half-life of CCK is about an hour to an hour and a half maximum. So when CCK is gone, automatically what will happen? The gallbladder will relax. When it relaxes, the stone will fall back into the gallbladder. This is in most of the time. Once the stone falls back into the gallbladder, the way is open, everything's fine, the pain subsides. يروح الألم. So that means that the pain lasted for an hour and a half, and patient relaxed. It went by itself, no need for any medication or anything, and it's a self-limiting controlled disease. If that occurs, this is what we call biliary colic. This is known as biliary colic. It is not cholecystitis. You do not have inflammation. You do not have infection. You do not have any problem or any disease. It's just a temporary, let's say it like this, it's a temporary obstruction of the cystic duct, which is relieved once you started or once you the CCK has moved. This is what we call biliary colic. Now, this is the commonest, and this is what happens. If the stone persists or stays into the duct and the obstruction persists, then you end up starting to have more pain or more persistent pain, and that with persistent pain, that persistent pain lasts for more than 2 hours. It's not related anymore to CCK. So the CCK is gone and the stone is still there blocking the cystic duct. And the pain persists more than 2 hours, then you start to have the inflammation and autodigestion in the bile, in the gallbladder by mucosal injury. This is what we call the next step in the pathophysiology. This is what we call acute cholecystitis. So biliary colic is self-limiting. It lasts for an hour or two and then subsides. It can progress into acute cholecystitis if the stone and the obstruction persists. So most of the time when you take a history from a patient, you'll see that he tells you, I've been having this problem for a year or two. Why didn't you go and seek medical attention? لما رحت المستشفى? Why didn't you do anything? يقول لك والله there was no need. Why? قبل ما أجي أقوم وبروح المستشفى أجي ما يقول راح لنا. طيب إيش سويت عشان راح لنا؟ ما سويت ولا شيء. خلاص وقفت أكل، قعدت ريلاكست شوية بنفسه راح. Okay. How often do you have this attack? يقول لك والله تجيني مرة في الشهر لما أتقل في الأكل بتصير عندي. لما ما أتقل وماشي الأمور تمام بتكون أوكي، ما بيصير عندي حاجة. So when he eats a big fatty meal, we have a strong contraction, more CCK, that pushes and moves these stones to obstruct the cystic duct. طيب إيش اللي جابك المرة هذه المستشفى؟ والله المرة دي غير كل مرة. قاعد الألم ساعة دحين، قلت أنا حيروح زي العادة، لو ساعتين 3 ساعات ولسه الألم موجود وبيزيد. So you know that this patient typically was having biliary colics due to the CCK and moving the stone here, there and here, and it was still moving. However, this time the stone went and blocked the cystic duct and stayed in the cystic duct, and the blockage is still there. And he went from biliary colic to acute cholecystitis. This shabat is extremely important. You have to understand this. I will be explaining it again and again في السيشنز في المستشفى لكل الجروبات. لكن you have to understand this presentation and this pathophysiology and what happens. And treatment when a patient comes with biliary colic is completely different from acute cholecystitis, is completely different from patients with complicated gallbladder disease. It's a big, big difference, and you have to recognize the patient, which one or where he is. On examination في الأكيوت cholecystitis, not biliary colic الآن بدنا نتكلم عن acute cholecystitis. It varies in severity. Usually there is right hypochondrial tenderness لأنه في biliary colic there is no pain anymore. There is muscle guarding rigidity. Sometimes you'll have rebound. لكن أهم حاجة you will have a Murphy sign positive. Murphy is cessation or stoppage of breathing due to pain on inspiration while you're putting your hand in the Murphy point, which is mid-clavicular line, 9th intercostal space. You press and ask the patient to take a deep breath. While he's taking a deep breath, the diaphragm lowers the liver, pushes the gallbladder. The gallbladder is inflamed, irritant, touches the peritoneum اللي انت دافه بيدك على جوا, and then automatically the patient cannot continue breathing. He will stop breathing. هيصير interruption. هتلاقي الجولبلادر عشان تطلع لفوق تاني لأنه he knows or automatically while he's breathing that this is causing more pain. So automatic من غير ما يحاول هو ولا يدري هو he will stop the breathing. So the pain goes. This is Murphy and it indicates an inflamed gallbladder. قلنا في biliary colic there is no inflammation. So this is very important to distinguish and differentiate between the two. Once you took a history, طبعا, from the patient, we're talking about a typical history, which is usually pain in the right upper quadrant, increased by fatty meal, radiated to the shoulder or to the scapula. طبعا it will be persistent for more than 6 hours to be acute cholecystitis. Sometimes fever or not, nausea and vomiting. There is usually a differential diagnosis. There are other diseases, very, very common, that can mimic cholecystitis. 2 of them you should never, never forget. The first one is the second dot, the perforated duodenal ulcer or peptic ulcer disease. Peptic ulcer disease a lot of times gives you the same presentation. Pain, right side, middle. There is no radiation to the tip of the shoulder, but also not everybody with cholecystitis has radiation. However, they have more history of heartburn, and this is why in the history we say you have to ask about heartburn, which is associated with peptic ulcer disease. Peptic ulcer disease and can mimic the same appearance of cholecystitis. The second differential important, hepatitis. Hepatitis is very common in our part of the world, and it presents with pain in the right upper quadrant. They will have tenderness from the inflamed, لأنه في inflammation, بس inflammation في الليفر ما هو في الجلد. They will not have Murphy of course لأنه ما حتوصل الليفر لتحت وتلمس إلا إذا كان عنده hepatomegaly. A radiation to the shoulder can occur because it's the same, irritating the phrenic nerve. لكن you have to ask for history for hepatitis, exposure, previous surgeries, blood transfusion, and all the risk factors that you know of hepatitis. طبعا part of the differential هدول الاثنين المهمين مرة, perforated duodenal ulcer and hepatitis. You can have other differential from other biliary diseases, and we'll talk about this next year: acute cholecystitis, chronic cholecystitis, acalcular, calcular, stones in the common bile duct, choroidocolithiasis. Also, do not forget if a differential causes of pain on the right side can be up in the chest, pneumonia, زي ما تكلمنا في المحاضرة وفي الجروب discussion of the upper abdominal pain. Don't forget the chest. You can have right-sided pneumonia giving you the same presentation. Lower lobe pneumonia. You can have appendix if it's a high riding appendix. You can have renal colic pancreatitis, all of this is part of the differential diagnosis, طبعا, which you will eliminate by taking a proper history and by doing a proper physical examination. So after we did the investigation or history, I mean, and we investigated we took a history, we examined the patient, we start with the investigation. Investigations for cholecystitis is extremely simple. You don't need much. طبعا, this is the normal investigations. If you have something else, you will have to investigate it accordingly. Now, for the routine investigations, first you need a CBC. You want to see the white cell count and see the amount of inflammation or if it went into infection or not. You want to see the platelets and the hemoglobin. Then you will ask for an LFT. طبعا ال LFT, you have to know, when you say LFT, you have to memorize by your heart the components. عندك ال AST وال ALT, which is liver enzymes, and they tell you the state of the liver in the acute state. So it's responsible for acute liver disease. You will find it elevated في acute liver disease زي hepatitis, hepatotoxicity, or any of the liver disease that can occur acutely. And importantly, you have to remember what I'm saying, acute. Okay. You will have the alkaline phosphatase, the third component of the LFT, and it will tell you the status of the biliary tree, if there is any biliary diseases or stones in the biliary tract or obstruction. Fourth component is bilirubin, and it's very important. It will tell you the status of the bilirubin of the jaundice of the patient. Once if it's elevated, then you can do the fractionated to see indirect and direct. That will tell you if it's a liver cause or prehepatic cause, or if it's a post-hepatic cause, اللي هو surgical, اللي هو obstruction, and then you know what type of jaundice he has. The fifth component is albumin, and it tells you the liver status, but the first one was acute. This is the chronic liver status. So if a patient has low albumin, it means he had chronic liver disease. He has been having liver disease long-standing for a long time. These five are very important. You have to know it. As I said, you have to know each one of them and what do they cause and why do they cause. So you can, when you ask for it, it's a screening tool, then you know how to think and where to think and what to do. After that, these are the first investigation, قلنا الوايت cell count. Second investigation, LFT. Third thing you have to do is hepatitis profile. لأنه قلنا من differential diagnosis is hepatitis. So you have to ask for hepatitis serology to be sure. This is the only investigations you need, the three. Now, if the patient is vomiting a lot, طبعا you'll have to ask for renal profile and electrolytes. If you're thinking عنده malignancy, لازم to ask for tumor marker. The rest of the investigation depends on the history and on the examination of the patient. You can add or not add for any reason you found or suspect. شاكك في بنكرياتايتس هتطلب amylase وليبase. فهذا كله are not routine. The routine are only the three I mentioned. After that, you will do imaging. X-ray is useless in the gallbladder or in the biliary tree all in general. لأنه قلنا stones هذه are not calcified, مو زي kidney stones. Kidney stones you can do an X-ray to see them لأنه في calcification. الgallbladder لا, you will not see them. Well, it's very rare to see a stone في الgallbladder في X-ray. So we do an ultrasound, which is the gold standard and the most important investigation in the gallbladder. أحسن من CT و MRI, أحسن investigation in the gallbladder is the ultrasound. So we look at the ultrasound, and when we order the ultrasound, we want to look at two things. The first thing is the gallbladder itself. We want to see the gallbladder wall thickness. And normal thickness is up to 3. Anything more than 3, 4 millimeter is thick wall. معناته في inflammation and edema. You want to see the sonographic Murphy sign. هذه sonographic Murphy sign, when the ultrasonographer is doing the ultrasound, is pushing the probe. And he will notice that the patient is stopping his breathing every time because the probe is being pushed. And he will write for you on the report while we're doing the examination. The patient's been having Murphy or sonographic Murphy. He's been having pain all the time. You will see the stones, but you will not see the stones itself. And I will show you pictures now. What will you see? So we'll leave that until the next slide. You will have pericholecystic fluid, which is normal fluid around the gallbladder, in inflammation, which is edema of the gallbladder. So the edema will be in the wall and around it, and I will show it to you now in the next picture. So this is what you see. Now, for you who don't know what ultrasound or how it works, so you understand the picture, ultrasound is sound waves, عبارة عن أمواج صوتية بتطلع من البروب من فوق هنا عند الكتابة وبتنزل في الجسم. كل ما تصقع حاجة وأنا عارف فين راحت المهم كل ما تصقع حاجة بتمشي خلال الفورم ماتيريال هذه أو الجسم with different densities. So when it goes, شوفوا زي ما انتم شايفين في النص أسود, when it goes in the middle, as you can see, it will cause أنا بحاول ألاقي لي drawing هذه لا ما نعرف فين راحت كانت موجودة بوينتر ما أدري فين شالوه غريب. ما نلاقي بوينترز. المهم بتشوفوا الفلويد هذه لما يكون يعدي الفلويد هيصير أسود لأنه الصوت بيعدي بسرعة. لما يعدي الفات زي ما انتم شايفين فوق وتحت هيديك a different kind of densities. These densities depend on the thickness of the tissue itself. So the sound waves are coming from up to down normally and hitting into the tissue and going back to the probe to tell you the different types of أنا أعرف كيف أبطلها بوينتر عشان أقدر أشوف. ما قادر العظيم حاجة يعني ما نعرف. ضايقتني. المهم ماني قادر أطلع لكم بوينتر أبارس أجرب القلم مو راضي حتى القلم مو راضي. وده يلون هذا يقدم لي الصورة لازم. طيب هذا اللي أنا هحاول أرسمه وأنتوا تشوفوا. المهم فهذه الحتة هحط فيها شوية ده حتى اللون مو باين. ما أدري ليش شالوها كده كيف شالوها في المنطقة. المهم طيب نرجع. فالثيكنس هذا depends على التشيو. بتشوف قلنا يرجع stones you will not see it زي كذا. هذا المريض عنده stones بس ما تشوف stones. What you see is the shadow, acoustic shadow مكتوب هنا تحت في رقم acoustic shadow. This is what you see which is the evidence of the stones. بتيجي الساوند ويفز بتسقع في الستونز هنا شوف عند الأسهم وبترجع. فما في ساوند ويفز ورا، ما في موجات صوتية ورا ستونز، فعشان كده يصير في ظل. شادو يعني ظل، فبتشوف الظل هذا indicative إنه هنا في حاجة ضربت في الساوند ويفز ورجعت. And this is what you see, the shadow. You don't see the stones, and we call it acoustic shadow. You'll see the thick wall. لو انتوا شايفينها هنا عند الأسهم فوق مكتوبة thick wall. Pericholecystic fluid، قلنا الفلويد بتكون سودة. شايفين السواد اللي في وسط الحتة، المفروض ما يكون، المفروض يكون كله أبيض زي كده. أي سواد معناته فلويد. فهذا edema around the wall، والwall is thick more than 4 ملم. وبتشوف الأكوستيك شادو، وبتشوف الجول بلادر dilated or كبيرة distended. And these are the 4 signs of acute calcular cholecystitis. So we have thick wall, pericholecystic fluid. The important thing is the acoustic shadow and the distended gallbladder. This is a very rare picture of stones in the gallbladder. As I said, you will never see this in your life. It's very, very rare. So we don't do X-rays for it, just to see it. And you don't even, don't think you'll see it again. So patient came to you with acute cholecystitis, and you diagnosed him after doing the ultrasound. What will you do? You'll put him MPO. Then you want the gallbladder to relax a little bit, so the CCK is gone, so the stone hopefully will fall back into the gallbladder. IV fluid with it. We do not give antibiotics. Everybody is trying to give antibiotics, and they give antibiotics عشان يعرف ينام. يقول لك يمكن يجيله infection، يعني هو يمكن يوقف ويطيح، يمكن. We don't treat patients على يمكن. So you should not give antibiotics. We know that this is inflammation. As we said, and antibiotics don't work on inflammation. So don't give antibiotics إلا لو عندك signs of infection. High white cell count, more than 20. High fever, more than 39. Then you're talking about a superimposed infection. And we are talking about a different diagnosis, as I said before. We're talking about complicated gallbladder disease. Then, okay, you want to give antibiotics. It's a different story because you have a different diagnosis and it's not acute cholecystitis. Once you do that, then you treat the patient with the definitive treatment, which is cholecystectomy. If the patient cannot go for surgery for any reason, very old, endocardiac problems, or he cannot do surgery now, then you can do a cholecystostomy. And then under radiology يفتحوا الجول and drain the gallbladder. So بدل ما drain من الcystic, it drains out and you can remove the stone. And this stops the vicious cycle of contracting gallbladder against stone auto digestion والبروبلم هذه. انت بتخرج البايل من طريق تاني عن طريق تيوب outside and you break the cycle، تكسر vicious cycle هذه until the patient is better and he can go for surgery and then you can take the gallbladder out. So the treatment is extremely simple. MPO and prepare the patient for surgery to take the gallbladder out as soon as possible. One of the stories that you will hear a lot, or the questions you will hear a lot everywhere, is prophylactic cholecystectomy. What do we mean by prophylactic? Prophylactic means that the patient came to you with an incidental gallbladder. Incidental gallstones, sorry, not gallbladder. Gallstones. Everybody has gallbladder. Came to you with incidental gallstones. What do they mean? Female راحت حامل مثلا وراحت تعمل ultrasound for the baby and they discovered she had stones في ultrasound. She didn't even complain about it. Somebody had chest pain and did an ultrasound in the chest. هم بيسووا lower chest شافوا الجولبلادر وفيها stones. Somebody was complaining of back pain and they did ultrasound and saw stones. Somebody has renal colic or renal stones and then they were doing the ultrasound and also saw gallbladder stones. So we are saying a patient discovered incidentally with gallstones they never complained about. And I told you at the beginning of the lecture, if you remember, 80% of people have stones, they do not have any complaint. فبيروحوا complain from something else, and during the investigation they find the stones. زمان يعني, they used to remove the gallbladder, saying that these patients will, they have stone, they will develop a problem later on. منهم البيدياتريك age group. In pediatrics, you can have stones نفس الطريقة. They will have the stone, the gallbladder moves, push it down. نفس القصة إياها, ما هي راحت يعني, ما تغيرت. They used to remove the gallbladder. يقول لك هذا المريض pediatric, he will live long time, so for sure بعد 50-40 سنة هتجيله مشاكل, أفضل نشيل الgallbladder. This it's no longer true. We don't do it anymore. Because these patients, the more they get older, they will eat better. Once they eat better and have a better fatty diet, the gallbladder works more and it ejects all of these stones out. And we've seen a lot of these pediatric group, they have stones, and after a while, when they're teenagers or adults, there is no more stones anymore. So we stopped removing them prophylactically. Prophylactically mean before they complain. Patients with hemolytic anemia, كل الانديكيشنز دي كانت موجودة. hemolytic anemia اللي هم اللي عندهم سيكل سيل وثلاسيميا وسبيروسايتوسيس زي ما قلت أول, يجوك يبغوا يشيل الجولبلادر, لأنه هدولي بيجوهم abdominal crisis وبيجيهم مشاكل, أحسن يشيل الجولبلادر so we don't get confused. They will develop stones. برضو نفس الطريقة. Not everybody develops stones, not all of them have problems, and we don't like to do surgery unnecessarily, so it's been kicked out. Patients with small stones or large stones برضو نفس الطريقة. اللي كانوا small stones يقول لك أحسن تشيلها, لأنه gallbladder will contract, يدف stone من السيستيك, يدفها ممكن blocked في الأمبولة ويصير لهم pancreatitis and they can die actually from pancreatitis. واللي big stone يقول لك it will block for sure هذه, و cause obstruction و get into cholecystitis وممكن perforation و fistula. نفس الطريقة. Not, as I said, 80% of patients don't have problem, so they stopped removing it. هعدي البورسلين واروح للي لو تلاحظوا الوحيد اللي ما عليه علامة استفهام, bariatric surgery. In the earlies, when patients started to have bariatric surgery اللي هو obesity surgery, they screened them and they found a lot of these patients have gallbladder. فبيقول لك يا ابوي أنا داخل أسوي تدبيس المعدة ولا باي باس, خلينا نشيل الجولبلادر مرة واحدة, لأنه لو هيجي لهم مشاكل بعد ما ياكلوا ويشربوا. actually هذه كانت من الأشياء اللي أنا looked into it زمان في 1990s, إنه نعمل الكوليستكتومي, لأنه لما تعمل الكوليستكتومي ما تقدر ترجع بعد كده أحسن للمريض وهو جيده عامل عمليات وبطنه معدومة ومدبس, ويصير له عنده problems من الجولبلادر وترجع تشيله المرارة. العملية هتكون أصعب ومشاكل أكتر. شيلها الآن لأنه هدول غالبا حيجيهم مشاكل. It's been proven بعد كده إنه لا, مو كلهم يجي لهم مشاكل, و not everybody will have problems. يعني إذا شلت الجولبلادر وصارت له مشكلة في العملية, أنت بتسأل يعني بتسأل على نفسك وبتفتح على نفسك أبواب ما لها داعي. It's out. We don't do it anymore. So not every patient going for bariatric surgery, if they have stones, we remove the gallbladder. We don't. كانوا برضو زمان فتحت بطنك مثلا بعمل لك عملية للكولون أو في الليفر أو في أي حتة, ودخلت لقيت الجولبلادر فيها stones, وزي ما قلنا لأنه 80% of people have stones, they don't complain. لقيت stones كانوا يشيلوها. الآن you are not allowed to remove it if it's not part of the surgery, حتى لو فيها stones, لأنه if you get a complication you cannot defend yourself of doing an unnecessary procedure. المريض هذا ممكن يعيش ويموت بالستونز هذه ولا يصير له أي حاجة, you should not remove it. قبل transplant, usually patients when they go for a kidney transplant زمان كانوا ولا ده يفتشوا, و during التفتيش يلاقوا عنده stones, فقالوا يا ابوي انت في العمليه كمان شيل الجول بلادر، ما نبغى المريض بعدين ياخذ اميونو سبريشن وياخذ مشاكل ويدخل لي في عمليه بعد كده ما اقدر اسوي له العمليه because of the medication he's having ودوب ويعمل transplant kidney bone whatever. So please take the gallbladder out. Also, this has been stopped and you don't do it. So all the reasons for prophylactic cholecystectomy has been removed and تقريبا ما صار في شيء اسمه prophylactic cholecystectomy except for هذه كلها كانت يعني من زمان في 1990s بداية 2000 كانت تتعمل إلا البورسلين جول بلادر، وعشان كده ما عليه علامة استفهام لو تلاحظوا. It is the only existing factor up to date to perform a prophylactic cholecystectomy. What is porcelain gallbladder? Porcelain gallbladder is complete calcification. دحين أجاوبك يا راغد دقيقة واحدة بسؤالك هذه. Complete calcification a complete calcification of the gallbladder with the stones. So بتعمل الالتراساوند بتلاقي calcification في الوول of the gallbladder, not part of the wall, the whole gallbladder. Part of the wall calcification is not porcelain. It's just a calcified gallbladder. Porcelain is calcification of the whole gallbladder. Full. تعمل اكس راي تشوف الجول بلادر كده كلها عبارة لأنها زي البون لأنها calcified. This is called porcelain gallbladder. And the reason is prophylactic cholecystectomy done in these cases is because porcelain gallbladder is pre-malignant. They will form malignancy of the gallbladder. And the worst, يا شباب, the worst cancer in the whole body is gallbladder cancer. It is worse than brain cancer, chest cancer, lung cancer in prognosis. The worst malignancy is gallbladder cancer. It's not easy, it's not treatable. Patients always die from it. You cannot treat it. It is a nightmare. So this is why porcelain gallbladder is the only indication for prophylactic cholecystectomy. إذا أنت عملت إكس راي المريض ما بيشتكي من أي حاجة، عملت إكس راي تشست وشفت الجول بلادر تعمل لها ألتراساوند وسي تي وتتأكد fully calcified you take it out even if the patient يقول لك طيب أنا جايك عندي مشكلة في الصدر، ما عليه في مشكلة في المرارة هذه لازم نشيلها وبعدين هنرجع على الصدر وهذه أخطر من اللي في الصدر. That you have to, this one you have to take it out. So this is the only indication for prophylactic cholecystectomy. رغد تسأل if a patient diabetic and has nephropathy, neuropathy, and incidentally discovered stones, still we do not take the gallbladder out. زمان كانوا diabetics uncontrolled وباد وعندهم stones يشيلوها لأنه يقول لك هذول they are immunocompromised and also they will develop stones. بس هذه زمان اتشالت لأنه patients unfortunately with stones, okay, or يعني you do it prophylactically, problems can happen in the surgery from the lab chole or the cholecystectomy. And if any problem happen, you have done surgery unnecessarily and you had complication. You cannot defend yourself, unfortunately. Now, this is different if a patient has any kind of pain. إذا عادت diabetic neuropathy وعنده abdominal pain خلاص it's a different story. So the only reason we do cholecystectomy is pain, number one, or complication. The patient comes with biliary colic multiple times or one time even, you and he wants cholecystectomy, you can do it. And the patient started the process of biliary colic, most likely they will develop pain and pain again and again, and they can develop acute cholecystitis. These are not prophylactic anymore. The patient has complained, even of a minor complaint, which is pain, or minor pain for 1 hour. Okay, and be sure it is the cause. You go and investigate and do it all your work, and then you take the gallbladder out. No problem. but this is not prophylactic. And the patient has complained. Prophylactic is what's the meaning? It means that the patient had stones and never ever complained of anything related to the stones. This is prophylactic. If they have a complaint related to the stones or anything related to the stones, لا طبعا. It's not prophylactic anymore. It's treatment, and you are justified to take the gallbladder out at that time. So we've been talking about complicated gallbladder disease. طبعا this is not your full scope this year. We will talk about this more next year. في biliary diseases, it's يعني SATSA is mainly hepatobiliary زي ما انتم عارفين, liver وبنكرياس والbiliary tree. لكن you should know some of the complications that can happen في when you have cholecystitis. And we said it's not called cholecystitis anymore. It will be called complicated cholecystitis or complicated gallbladder disease. طبعا you can have fluid and electrolyte disturbance من النوزيا والvomiting, وهذه اللي قلنا عليها, and you can end up even حتى with renal failure and nephropathy, severe diabetes, nausea and vomiting. And this is when we said you do a renal profile and you do electrolytes to check. You can have empyema, and this is infection of the gallbladder. So infection is called empyema, when the gallbladder is filled with pus. The gallbladder is obstructed والinfection بدأ يصير فيتحول البايل لبس, and this is, the patient will be very toxic, high fever. You can have emphysema, which is another type of infection, gas producing organism, and then you have gas in the wall of the gallbladder. And it's usually, this is more common in diabetic men, and they are more immunocompromised, so they will develop this, and they will have severe right upper quadrant pain, sepsis, and then you'll do the imaging and you'll see air in the wall of the gallbladder. This is how we diagnose it usually, by air in the wall of the gallbladder. لأنه المريض أول شيء لو جاك septic وهاي fever وهاي toxic أنت تقول عنده infection. Both of them is the same treatment, cholecystectomy, antibiotic and then cholecystectomy. If it's empyema or emphysema, the only way you will differentiate is by the ultrasound, and usually there is not a big issue if you differentiate or don't differentiate. It doesn't make a difference. The treatment is the same. You have to give antibiotics, stabilize the patient, and take the gallbladder out as quick as possible. بس الفرق إنه empyema is pus, definition. Emphysema is air, gas producing organism. The gallbladder can perforate, gangrene, scarring, يصير thin wall, perforates, and then the bile goes into the abdominal cavity. Bile, يا شباب شابات, is the worst irritant. It's worse than acid. It's worse than the stomach acidity, HCl. It's the worst irritant. Biliary peritonitis is the worst peritonitis. أخس من feces, urine, everything else. It eats up everything. It's very alkalytic, very strong alkalytic agent. وتاكل كل شيء, and it causes a lot of problems. So biliary peritonitis is a very serious, dangerous, with a high morbidity and a very high mortality. Fistula can form from the stones. Stone هذه بتحك في نفس gallbladder wall, if it's a large stone especially, and we'll talk next year about Parisi. This is one of the type, one of the diseases of fistula formation. بتحك في gallbladder wall, والgallbladder يكون next to the colon or next to a small bowel, وتدخل وتحك بعدين في small bowel وتعمل fistula بين الاثنين. This fistula can cause gallstone ileus, which is one of the common problems, and you should know about gallstone ileus and read about it. That can give you intestinal obstruction from the stone. The stone doesn't fall from the cystic duct and the ampulla, لأنه لو stone طاحت من السيستيك والأمبولا ما حتسوي intestinal obstruction لأنها very small ولا ما كان عدت من السيستيك والأمبولا. لكن لما تعمل فيستولا تكون كبيرة وتدخل في small bowel عن طريق الفيستولا, توصل عند السيلياك عند end of the small bowel اللي هو لا إله إلا الله celiac valve بداية large bowel, and that's where the common site, the narrowest part is, and it obstructs. And then you end up with intestinal obstruction. And this is called gallstone ileus. Ileus obstruction caused by gallstone. فأنت تفكر طب كيف الستون هذه تعمل obstruction? It cannot. It's too small because it passed from the cystic and the ampulla. لا، هذه جات عن طريق فيستولا في small bowel وكبيرة، وأول ما جات للناروست area اليوسيكال فالف، أنا بحاول أفتكر سوري صار لي منتال بلوك. اليوسيك أول ما توصل الإليوسيكال فالف هناك أضيق حتة تقفل، لما تقفل هناك بتسوي لك intestinal obstruction, and this is called gallstone ileus. زي ما قلنا you can have perforation with abscess formation وتكلمنا عليها. You can have fistula formation, peritonitis, gallstone, pancreatitis. The gallstone can enter from the cystic into the ampulla and block the ampulla and cause pancreatitis, and it's one of the commonest causes of pancreatitis, actually the commonest cause of pancreatitis. بعد الجولستون يجي pancreatitis يجي alcoholic pancreatitis. You can have ascending cholangitis. stone تنزل من السيستيك داكت وتقعد في الكومن بايل داكت and causes obstruction في الأمبولة نفسها وتقعد هناك, and then you have obstructive jaundice, and that will cause ascending or cholangitis, which is infection of the biliary tree, not the gallbladder. Cholangitis is infection of the biliary tree, not inflammation. لاحظوا هذيك كانت inflammation. Cholangitis is infection, and we will talk about it next year, but cholangitis in general, but this is also one of the commonest complications. Any of this can happen from gallstone disease or acute calcular cholecystitis. If any of this happen, you don't call it calcular cholecystitis anymore. You call it complicated cholecystitis or complicated gallbladder disease. هي كانت gallbladder disease that became complicated with whatever you want to pick up from the list. غلقنا الكالكولر cholecystitis. الآن هتكلم في 2 slides على 3 other modalities which is very simple. طيب أول واحدة نحن قلنا هي 4 very سهل إنك تعرفها. عندك acute وchronic، وعندك calcular ونون calcular. فعندك acute calcular cholecystitis، هذه اللي اتكلمنا عليها المحاضرة دي كلها ساعة ونص ورحنا نذبح ونتكلم فيها. You can have acute acalcular cholecystitis. معناته وقلنا لما يكون الكوليسيستايتس ما فيها ستونز لازم هيقول لك acalcular cholecystitis، لكن ممكن يقول acute cholecystitis معناته ستون موجودة لأنها هي الكومنست. You can have also chronic calcular cholecystitis and chronic acalcular cholecystitis. هم 4. The commonest قلنا 95% is calcular cholecystitis or acute cholecystitis زي ما تكلمنا. Now the second arm is acute acalcular cholecystitis. معناته you have cholecystitis which is acute بس the cause is not a stone, and this can happen but in special circumstances, and it's very important. You have to know it. You have to recognize it properly. It's very simple. What happens? This happens in patient after usually المريض يكون very sick from other things, either severe trauma, severe burn, septic, وusually في ICU يكون المريض. فهذا مريض يكون very sick from other things. common زي ما قلنا هم 4: trauma, burn, sepsis. usually الرابعة ما هي مكتوبة هنا which is after cardiac open heart surgery. فهذول المرضى يكون complicated open heart surgery يعني بعد صارت مشاكل وقاعد في ICU. usually these guys are fasting. لا تنسوا قلنا هذا الكلام من أول which is the commonest cause. prolonged fasting ما هم قادرين يأكلوا ويشربوا. comatose على الفنتليتر. فthere is stasis in the bile. Usually they're very sick septic. That means the whole body is inflamed and edematous and they're getting a lot of IV fluid. So what happens زي ما قلنا في البداية في الكالكولر كوليستايتس ايش السبب؟ obstruction of the cystic duct. Here you have obstruction also, but the obstruction is not caused by a stone. It is caused by the edema of the gallbladder لأنه السيستيك duct صغيرة very thin، فيصير عندك edema مع الديهايدريشن اللي موجودة مع ستيسيس الجولبلادر ما هي شغالة. You get the autodigestion inflammation and goes directly because of the immune compromised. They start to go into infection and you end up with cholecystitis without a stone or without a real genuine obstruction. It's usually caused because of the edema of the gallbladder narrowing the cystic duct with dehydration and edema and inflammation of the whole body from the sepsis and the MPO factor of not eating in the ICU. So you will never see this condition except in very sick patients. You will never see it in a patient walking into the ER. It doesn't exist. This is always in patients already in the hospital for a long time with major other problems, and they develop this problem on top of it. So it's well-known hospital entity. Always the surgeons get called about it في ICU for medical or any other surgical patients. يجي يقول لك المريض عنده SAR، بدأ يصير عنده فيفر وعنده ما احنا لاقين سبب الفيفر، أو إذا كان المريض شوية صاحي يصير عنده severe right upper quadrant pain. ICU قبل ما يكلمون كالعادة بيطلبوا الالتراساوند. يجي الالتراساوند يقول لك الجولبلادر distended, dilated, thick wall with pericholecystic fluid. And we did the examination, we find the Murphy sign positive and he is having severe pain for right upper quadrant. The only difference is one thing يا شباب. There is no acoustic shadow. There is no stones. مفهوم؟ I hope it's clear. It's the same. The only difference is there is no stones on ultrasound. So then you know that this patient, and you already took history, you found out he's already very sick, he's been in ICU for some time, struggling, having problems, not eating properly. So then you know this is acute acalcular cholecystitis. Now we talk about the treatment. Acute acalcular, no stones, cholecystitis is much, much, much worse than calcular cholecystitis. ليه؟ أول شيء قلنا infection هذا already. It starts by infection. Number two قلنا إنه المريض هذا already is very sick. هو أصلا مو زي اللي جاي ماشي برجله وأموره تمام. It is much more surgical emergency and treatment has to be done quickly. Or he will perforate his gallbladder or end up in paima and septic on top of his sepsis already هو قيده مريض and dies. It is a much more serious disease, number one. Number two, these patients are sick already. If you can, the treatment is the same. Try to do a cholecystectomy. But unfortunately, a lot of the times you cannot take them to the OR. He's severe burn everywhere. ولا يكون دوبه مغلق cardiac surgery تعبان ومو قادر يتحرك، ولا يكون septic. He cannot go to the OR. ولا trauma هرشم زي ما قلنا. You cannot take them to the OR. If you can take him to the OR, take him to the OR directly and do the cholecystectomy. Don't wait. It is a surgical emergency, really, much more than the calcular cholecystitis. However, if you can't take him to the OR, this is where cholecystostomy, opening the gallbladder and draining it, is a must and has to be done very quickly, and you start antibiotics. You have to do it. You have to break the cycle, either by cholecystectomy or cholecystostomy, putting tube in the gallbladder and emptying the gallbladder from bile and preventing further infection and starting antibiotics. So it is a very serious disease and it is very life-threatening. قلنا السبب ليه وقلنا how you can differentiate it between the calcular. It's usually sicker patients with no stones. الباقي كله نفسه ما يحتاج نعيد ونزيد. I hope it's clear. So this is acute. أنا بس أبغاكم تعرفوا لأنه هي خلاص إذا فهمتوا الكالكولر cholecystitis or acute cholecystitis I should say الباقي is easy. It depends عليها. This one we said the difference between it. Then we have chronic cholecystitis. Chronic calcular cholecystitis is the same as acute calcular cholecystitis. These patients have been having the same issue, acute attack, راح البيت ما شال الجول بلادر، جاء بعد شهرين another acute attack ما شال الجول بلادر، بعد سنة ممكن another acute attack ما شال الجول بلادر، قاعد يتدلع الأخ until the whole gallbladder becomes fibrosed. كل attack قلنا there will be part of fibrosis ويرجع another part fibrosed ويرجع third part fibrosed ويرجع بعد كده الجولبلادر كله will be fibrosed. So you will have a totally fibrosed gallbladder. When the gallbladder becomes fibrosed, presentation changes. ليه؟ Number one, CCK will not work anymore on the gallbladder. There is no more muscle, it's all fibrosis. The gallbladder is fibrosed, so it will become shrunken, it will not distend. There will be no edema or thick wall. The presentation changes. Number one, they will have persistent pain من الفibrosis or shrunken gallbladder على طول. It's not related to food anymore, not related to CCK. يقول لك أشرب جغمة موية الألم يجيني. They cannot eat or drink, so it's a persistent pain, not related to food, زي الacute cholecystitis. You do the ultrasound, you do not see a distended gallbladder, هتلاقيها shrunken gallbladder. ما في perichorecystic fluid، هتشوف stones in a shrunken fibrosed gallbladder. This is called chronic cholecystitis. So the difference, the pain will be on history and on presentation persistent. When you examine the patient, there will be no Murphy sign. لأنه قلنا Murphy sign is a distended gallbladder that is inflamed. There is no more inflammation في الكرونيك. تعمل ميرفي ما حتوصل حتى للجولبلادر. ليه؟ لأن الجولبلادر shrunken fibrosed فما حتى لما he breathes it doesn't reach down to your hand. So these are the difference when you diagnose chronic cholecystitis. Now when you diagnose chronic cholecystitis, for your level, it's the same. Treatment is the same. MPO, IV fluid, take him to the OR. However, whoever goes into surgery, بعد كده هيعرف العملية for chronic cholecystitis is much more difficult. Not everybody can do it. And a fibrosed gallbladder, shrunken, went inside into the gallbladder, the whole area become fibrosed. They're more prone to develop injuries during the operation. فالعملية تكون أصعب كتير. So you need to know the difference when you diagnose. رغد بتسأل, is the pain relieved between the attacks? No, there is no attacks anymore with chronic. Pain is persistent all the time. The pain doesn't go في chronic cholecystitis لأنه خلاص الجولبلادر هتفضل fibrosed shrunken contracted causing the pain. There is no more relief. There is no more attacks anymore زي الacute. Chronic is a persistent pain all the time. A treatment is the same, but it is different and more difficult. So for you, you need to know the difference between acute and chronic. There is nothing called, زي ما قلت للسيشن للناس اللي قبلكم الفيميلز, there is nothing called recurrent acute or a persistent acute or acute on chronic. هذا كله rubbish. It's either acute, it's either biliary colic زي ما قلنا في البداية, self-controlled limiting attack for 1 hour and it goes by itself with no problems, or acute cholecystitis, persistent attack more than 6 hours, pain subsides after that, and there is signs on ultrasounds of acute with a positive Murphy. Or chronic, which is continuous pain, not related to food, no Murphy, ultrasound, shrunken, contracted gallbladder, and this is chronic. That is it. There is no other definitions. If a patient had an acute attack and was treated, went home and was booked for surgery, and عبال ما يجيله دوره في العمليات جاته another episode وجاء ER, it is called acute. It's not called recurrent acute. No, it's not recurrent. This is a completely new attack with a new diagnosis. He was treated from the first one, it's over, and now he had another attack, so it's called again acute cholecystitis. ما لها دعوة، لا تقولي recurrent ولا تقولي periodic ولا الكلام ده كله ما له داعي. It is acute cholecystitis. Okay. If you mean before, رغد بتقول I mean before fibrosis. Before fibrosis, you will get acute cholecystitis. The pain is relieved between the attacks. Yes, the pain goes completely. في acute cholecystitis, if it doesn't go into complication, the pain lasts for 6, maximum 12 hours. It will go with medication or non-steroidal anti-inflammatory, Panadol or whatever you give. Patient relaxes, يروح الألم. لأنه eventually الستون حتطيح تاني. إذا ما طاحت وقعدت obstruction, you will develop complication or infection. But the pain goes. After that, you book the patient for surgery. أحيانا ما تقدر تسوي العملية for any reason. مستشفى ما في غرفة عمليات، السيرجن في إجازة، الأسباب الكثيرة اللي هي ما لها دعوة، non medical causes نسميها. فيجي المريض أول ما بيستنى دوره في العمليات تجي له another attack. راح الأخ أكل بيتزا ولا أكل برجر، اشتهى وراح وضرب وجاته contraction وضفت ستون تاني وجاله pain. هذه it's just simply acute cholecystitis, another attack. It doesn't make a difference. So don't call it periodic or recurrent. It's not. It is acute cholecystitis. If the pain lasted and the ultrasound changed it, then it is chronic cholecystitis. Now, people can have, there is no rule for it. How many attacks of biliary colic you need before you develop acute cholecystitis? ما لها دعوة. You can develop acute cholecystitis at the first attack and never had biliary colic. ممكن أول attack contracted وستون راحت وسدت. You did not have any previous history of biliary colic. Or you could have had 10 attacks of biliary colic. ما لها قاعدة. The same with the acute. You can have one attack of acute and go to chronic. على طول. It was a severe attack. The whole gallbladder got fibrosed and انتهى الموضوع. And you can, or on the other hand, you can have 10 attacks of acute before you go into chronic. Or you can keep continuing having acute attacks and never go to chronic. ما لها قاعدة، ما لها number، ما لها وقت، ما في أي شيء من ذا الكلام. لأنه the human body is different from one to another. The attack is different, the severity from one to another. So you cannot take it as a rule. لأنه المريض لازم biliary colic، بعدين لازم acute، بعدين لازم chronic. هذا this is not the case whatsoever. The last entity I want to talk about is chronic, the same, but acalcular. بنقولها chronic acalcular cholecystitis. Now this is cholecystitis, but the cause is no stones and it's chronic. You don't see the manifestations of acute on ultrasound and on examination. This is a rare entity لكنها موجودة. It was not recognized until about 2000. رسالة الدكتوراه حقتي أنا عليها كانت في 1990s. And it is talking about it is usually now called non-functioning gallbladder. المريض هذا يكون عندهم usually females يكون عندهم akinesia of the gallbladder لأنه عندهم anomaly. ما عندهم receptors. One of the types are commonest of the types. ما عندهم receptors للسي سي كي في الجولبلادر. فهو يأكل ويشرب طبيعي لكن الجولبلادر doesn't respond to CCK. Simple as that. فاهمين؟ It doesn't respond to CCK لأنه receptors ما في. فيأكل الجولبلادر doesn't empty. It is not obstruction. لكن عشان stasis of the bile, the patient starts to have auto digestion لأنه البايل قاعد وكل ما ياكلوا بيصير عندهم more concentrated bile, and they start to have dull aching, mild irritant pain, ما هو severe irritant pain on the right side of the abdomen. وتلاقي المرضى دول شافوا دكتور واثنين وثلاثة وأربعة لين ما حد recognize لأنه هذه rare until somebody recognizes it. يعمل الترا ساوند الجول ياخذ هيستوري اوكي هذه شكلها جول بلادر ديزيز، يعمل الترا ساوند there is no stones, no inflammation, no polycystic fluid, not distended gallbladder. طب هذه كلها طبيعي الجول. يقول له ما عندك شيء روحي، ترجع بعد اسبوع اسبوعين نفس الطريقه، الالم يا دكتور لسه وكل ما اكل بيزيد وبيضايقني، ما هو الم شديد لكن مضايق. تعيد الالترا ساوند ثاني نفس الكلام، تقول لا ما في شيء، تروح لدكتور ثاني نفس الطريقه، تقول هذا حمار ما يفهم تروح للثاني، تقول له ده ما يفهم تروح للثاني، تلاقيها شافت كذا دكتور لين ما somebody thinks of it. So what happens when somebody recognizes it? He wants to diagnose it that this is a non-functioning gallbladder. زمان كانوا يعملوا الهايد سكان. This was the only entity where they used to do hide scan. Now nobody does hide scan anymore. I know they write it in books still, but you should not do it and you will not find it in any hospital. خلاص الجهاز اترمى، يستعملوا فيه أشياء تانية. كانوا يدوا الكونتراست ويشوفوا الجول بلادر functioning ولا لا. كانت it picks up some of the cases and other cases it doesn't pick up. It doesn't pick up every case. لكن now the way we test it is by injecting CCK. أول ما بدأ التست كانوا يخلوا المريض يروح ياكل، يقولوا روح كل بيتزا وتعال. المريض يعمل الالترا ساوند يلاقوا الجول بلادر مثلا 20 سنتي لأنها مليانة بايل ودايليتد ونورمال، يقولوا له يروح كل بيتزا وتعال، يروح ياكل ويرجع ويسوي الالترا ساوند تاني. المفروض الجول بلادر شرينكس لأنه السي سي كي طلع كونتراكتد، وبعد كده 10 دقائق يقيسوا تاني، تبدأ بعد كده لأنه السي سي كي يبدأ يروح تبدأ تفتح زي الهارت ejection fraction. You cause the ejection, the heart to contract, and then you see it dilate to fill up with blood. طبعا the heart is much faster. The gallbladder takes over an hour. بعد كده لقوا إنه telling the patient to go and eat and come back is not fixed. واحد يروح ياكل لي قطعة بيتزا، واحد يروح ياكل بيتزا كاملة، واحد يضحك عليهم وما ياكل، فصاروا يحقنوا 75 milligrams of CCK IV كأنه أكل. So what happens, how we do the test, it's called ultrasound ejection fraction, gallbladder ejection fraction, or gallbladder kinetics. يعمل الالتراساوند very very simple، يعمل الالتراساوند يقيس الجولبلادر، يحقنه بالسي سي كي 5 دقائق بعد السي سي كي يقيس الجولبلادر، مفروض تكونتراكت another 10 minutes قيس، مفروض كونتراكت زيادة، بعدها نص ساعة يستنى، مفروض الجولبلادر begins to dilate ويلم البايل، يعمل الالتراساوند، بعد بنص ساعة تانية التراساوند، ما تاخذ دقيقة بس he measures, he doesn't do the whole abdomen، بس يقيس الجولبلادر، وبعدها بساعة ونص يقيس الالتراساوند تاني الجولبلادر and it should be back to normal. فإذا ما في ejection fraction of about 75% of the volume of the gallbladder itself بعد ما حقنت السي سي كي، تعرف إنه هذه الجولبلادر is not responding to CCK, so it's not functioning. And this is what we call chronic acalcular. معناتها chronic, it's a congenital anomaly, ما في stones, cholecystitis causing pain, and because of the inflammation there is no infection, and we take the patient. Usually the treatment is very simple, a very simple, straightforward, very easy cholecystectomy and a normal gallbladder. It's congenital, non-functioning. We take it out والبين يروح والأمور تصير تمام. This is called chronic acalcular cholecystitis, or another term for it, you can say non-functioning gallbladder. These are the 4 entities of cholecystitis. I hope it's clear. You don't need to know this, don't bother. اديكم example. This is what usually happens في الIR. A 46-year-old female with a 4 history of nausea, right upper quadrant pain radiating to the right scapula. Symptoms began 1 hour ago only. After a fatty meal, patient currently has no pain. Now she has no pain. Had multiple similar episodes before. History of a similar pain several times before. This is the normal history. Right upper on examination, right upper quadrant, no Murphy. Murphy is negative. No leukocytosis, LFT is normal. Ultrasound showed this typical picture. As you can see, the acoustic shadow very clear. شايفين الشادو الأسود، حتى في نقاط بتشوف ستونز، هذه دائما تشوفها. There is no dilated gallbladder زي الصورة ديك. The wall is normal شايفينها. And there is no polycystic fluid. كلها عبارة عن acoustic shadow بس شايف stones. So what's your differential diagnosis? What's the diagnosis actually? This is biliary colic. شاطرة شهداء عبد الله. This is typical biliary colic. What is the treatment? Anybody with biliary colic, we do not admit to the hospital. لو أنت في الليل مناوب resident house officer intern وجاك biliary colic ودخلته، ما هو chronic cholecystitis هذا يا أبو الشباب، لأنه ما في fibrosis والجول بلادر normal. وهذه إذا أنت دخلته المستشفى ببيليري كوليك، تاني يوم الصباح هيشرحوك ويعلقوك، لأنه لو كل مريض جانا ببيليري كوليك دخلناه المستشفى هنقفل المستشفيات. And it's a self-limiting condition. You give them IV fluid، اديها بنادور، قول لها إذا زاد عليك ألم ولا صار شيء وتديها موعد في العيادة early appointment quick. تاني يوم اليوم اللي بعده تروح العيادة تقول لهم اللي صار. They will investigate her in the clinic and prepare her for elective cholecystectomy. لكن لو المريض جاب acute cholecystitis غير، وقلنا الفروقات وقلت لكم هي في الهيستوري اللي فاتت. هذا البين persistent Murphy positive ultrasound shows signs of acute اللي هي polycystic fluid thick wall and distended gallbladder. Then this patient الوايت سيل هتلاقي عالي شوية عشان الانفلاميشن، هتلاقي شو اسمه دي fever low grade fever عشان الانفلاميشن. هذا البيشنت you admit، لأنه you don't want him to go into complication. This is why I'm admitting him. لأنه he might go home and develop complication. لكن biliary colic never ever admit, please. I hope it's clear. Thank you very much. If you have any question, ask. أخذوا معايا السيشن already، تكلمنا معهم عن الموضوع، فهم معتبرين هذا كان تكرار، والتكرار يعلم الشطار. الجروبات اللي لسه ما أخذت معايا هتاخد معايا في المستشفى، هنتكلم عن الموضوع ده ثاني وثالث from a clinical point of view، لأنه cholecystitis is the commonest surgical condition. مستحيل تناوب في المستشفى جراحة ولا امتياز ما تشوف cholecystitis كل يوم. مستحيل تعدي في المستشفى ما تلاقي gall bladder وcholecystectomy lab كل done every day. مستحيل إنه تدخل الجناح وما تشوفها. ف it is the commonest. You have to know it by heart. مستحيل تعدي اختبار 2 ما تشوف gall bladder disease وcholecystitis. You have to know it by heart. It's not a rare disease. فإذا جات وما عرفت تجاوب على أي سؤال فيها you fail directly، لأنها very very common. زي الدايابيتس في الميديسن، واحد يسألك سؤال في الدايابيتس ما تعرف تجاوبه الله يعينك. هذه الجول بلادر عندنا في الجراحة نفس الشيء. فwe'll talk about it again في السيشن مع كل الجروبات. Acute cholecystitis from a clinical point of view, we will be repeating a lot of these things and you have to know it by heart. طبعا في سادسة حنتبحر فيها زيادة. ما عندكم أي سؤال، جزاكم الله خير and we'll see you إن شاء الله في السيشن يوم الثلاث بعد الظهر whoever is معي الأولاد.